Thank you so much for joining me. My name's Ibrahim, and I am coming live from Chicago. I live right outside of Chicago in the suburb called Naperville, and I am a mom of 2 boys and a dog. I am married to a prosthodontist, and we share a lot of teeth love together. A little bit about my background. I did bioengineering and did dental school at the University of Illinois in Chicago. After that, I went on to become a prosthodontist. I did a 3-year program at the UIC. And I practiced prosthodontics for quite a while in a suburb outside of Chicago. Then I started to think about the important relationship between orthodontics and prosthodontics. And I decided to go back to school to become an orthodontist, and I went to NYU, and I had an amazing experience there. And once I graduated, I decided to dedicate my time to only orthodontics at this point. I do share a practice with my husband, Anthony Lavaca. He's a prosthodontist, and together we have a pediatric practice, an orthodontic, and general dental practice where we have oral surgery, endo, pedo, prosthodontics, of course, oral surgery. And so we get to do a lot of really amazing cases together, and it really gives me the opportunity to treat the patients that I love, the really complex prosthodontic patients or patients with a lot of complexity. So that's given me a really nice opportunity to really expand my horizons, both in prosthodontics while doing the ortho at the same time. I practice with 2 amazing doctors, Dr. Ibrahim, whom I've known since dental school, so quite a while, and Dr. Jin, an amazing orthodontist, and we have so much fun together in the office. We've created sort of a space that doesn't really feel like a dental practice, so in hopes that people, when they come in, they kind of feel like it's more of an experience versus the kind of cold, sterile, stereotypical dental office. I know a lot of orthodontists also aim for that really comfortable, welcoming environment. So it's been a lot of fun. Today, I'm going to talk a little bit about technology-driven orthodontics and how we can use technology to really carve out an amazing pathway to predictable treatment for our patients. Pathway to predictability, I think for all of us, we can agree is really what we want every day in our practice. And I really believe that for me, vibration technology has been a really incredible part of my practice that I offer my patients. So we'll go through a little bit of the science supporting vibration technology. We'll talk about how we can really get great predictability even with the most complex types of cases we treat. We'll talk a little bit today about how we can really get amazing efficiency with aligner patients, and talk about how when we have compliance, it really does affect our profitability and how that impacts our entire practice. Patient compliance is so important, as we all know. Science behind vibration, it's really fascinating to me because there's a lot of similarity, of course, with the vibration that's used in the orthopedic industry. So vibration or acceleration really comes from the orthopedic industry, where they used vibration to help with bone healing. And they've recognized this for many, many years. And they use it with such like the TENS unit and the vibrating plate. And we know that patients get a tremendous amount of enhancement to bone healing and improvement in fractures and things like that because we're actually increasing the bone density. So this technology isn't really new. I think where it's new is applying it into the mouth. And in the beginning, it almost sounds like you're vibrating teeth so fast, you're going to cause bone loss. But it's not really how this works. This vibration allows teeth to move in a really, really biologic way where you're not imposing a tremendous amount of force to cause teeth to move, but you're actually working with the bone cells, the bone turnover rate, and the remodeling to help facilitate tooth movement. It has been absolutely tremendous in terms of what efficiency and predictability I've been able to achieve with our patients. And I'd really like to share that in the upcoming presentation with you so that you could really see how it's changed my life and our practice significantly. When we think about, treating patients, I think that what they want is sometimes not exactly what we want. As orthodontists, the most important thing for us is really predictability, meaning when the patient comes in and we promise them a certain kind of treatment, we want to be able to deliver on that treatment. Oftentimes, though, patients come in and they want treatment fast. They want it fast and they want to know, okay, how long is this going to take? And it's always that kind of battle because we want them to get the treatment. We don't want to discourage them that it's going to take longer than they want, but we also want to make sure that we achieve excellent predictability. And I think that's kind of where we're at today with our practice, because people come in and they are very well informed and they do know what they want. And it's our job to be able to deliver it to them the best way that we can. I have been doing Invisalign using clear aligners since the early 2000s, and I got trained at NYU, actually not having a whole lot of experience, and have learned a lot since those days. I've treated over 3,000 Invisalign patients and about 3,500, if not close to 4,000 patients with vibration acceleration treatment. And doing a lot of Invisalign, you kind of learn some of the pitfalls and some of the successes that you have. And with more experience as a provider, I think you're going to have a lot more success delivering really great Invisalign treatment or aligner treatment in general. It takes a lot of other things, though, to get the success. You have to have a really realistic treatment plan. You have to be sure that your patient is really, really compliant. You also have to make sure that all the program movements in every aligner are fully expressed. And that, to me, is probably the most important of these four really, really important elements to get successful aligner results. Because even if I have a really amazing patient who's super compliant, I've created a really realistic treatment plan with the proper number of aligners and the proper amount of, rate of tooth movement, and I've got the experience. If I don't get every movement out of one tray, I'm not going to get the proper movement out of the second tray. So I found that when I use vibration along with my clear aligners, I am getting every programmed movement out of these aligners. It's really has helped me, and I've seen it, get those movements expressed onto the teeth so we can get the result that that ClinCheck cartoon promises the patient and that result that we're aiming for. I don't really love the term acceleration, even though we do talk about providing accelerated treatment for our patients. Because acceleration means to me, or seems to sound like, we're going to rush through the treatment and accelerate it. But what it really means is that we are getting the predictability by getting every program movement out of those trays so that we can get to that finish line that we were hoping for. And I do believe 100% that bringing in vibration technology into the practice has really helped us to do that. When we think about using aligners, and we think about using it for the really simple cases, we pretty much know that we're going to get those simple movements expressed out of every tray, but what about those really complex movements that even Invisalign says, hey, you know, your tooth movement assessment, you're going to get blue dots and black dots because these movements are really, really hard. And we know what those are. They're your rotations, the extrusions, translation of the root, but we want to be able to offer that type of treatment for our patient. I know that it's been recommended that we can change aligners once a week, but when we have those really complex movements, how are we getting those movements expressed onto the teeth while still trying to keep with that 1 week aligner change? I think it's really, really hard unless you incorporate a medical device such as VPRO into your armamentarium, and that's what we do in our office. When I see a patient for the very first time in a consult, I want to be able to give them something to aim for. And most patients, I will tell them, for example, your treatment might take 1.5 years, but at 8 months, you'll be about 90% done with your treatment. So when I say that to a patient, that's kind of my finish line. And I want to work really, really hard to get to that finish line with really good efficiency and give them that predictable result. Otherwise, I don't look like I'm being honest with them. I want to be able to cross that finish line and give them that result that I want. My typical protocol is the same as it was without incorporating a vibration device such as VPRO. When I started using it, I didn't change anything. I kept the same rate of tooth movement. I kept the same number of aligners to get that result that I know it would take. I kept all the same auxiliaries, you know, the buttons, the elastics, all those types of things that I've used before. All I did was ask the patient to wear the aligners for 1 week instead of what typically could have been 2 weeks. Because I usually would have people wear each aligner for about 2 weeks to get those results. So it was a really simple switch for me because all I did was bring in my acceleration vibration technology and I gave it out to every single patient along with their aligners, and I didn't do anything differently except I asked them to wear their aligners just for 1 week. With their aligners in place, once a day, they use the VPRO for 5 minutes only. And people don't really have a problem with it. It just becomes part of their daily routine, and 5 minutes goes by like that. I do tell patients that if they skip the VPRO 1 day, they have to wear the tray 2 extra days, because if we don't get those program movements out of that tray and they change it too quickly, then they're going to be behind. Every tray from there on in is going to be behind. And most often people will come in on tray number 10 and it won't even seat because they've kind of rushed through and they haven't taken the time to get every movement out of every aligner. Once you tell them that, by the way, they definitely use it every day because they don't want to add any more time to their treatment. One of the things that I did in the beginning was I took cases that looked very similar to me, and I wanted to compare the treatment times to see, am I really saving time by using these devices? Is it really making a difference in my practice? I will tell you that in 2013, that was kind of the very first time that I tried using vibration devices. And it was because I went to a lecture and I saw a fantastic doctor show these cases. And he was doing it with a vibration device, and I couldn't believe he had them changing trays every week. And I thought, okay, this is amazing. It's giving me something to go back home and try out. And so sure enough, I started using the devices with every patient that I started. And this is one example of a comparison that I made. These two patients, they're not twins, just tooth twins. They are a very similar age. They both have the blacked out canine. I would say Abby's treatment might be a little bit simpler in terms of, you know, the crowding maybe isn't as severe as Leo's, but I treated Abby without vibration technology, and I treated Leo with, and I want to show you what I saw, which I thought was really fascinating in terms of the result. When we started her treatment, you could see she had a significant amount of crowding, narrow arches, you know, about a 50% deep bite. We did her initial workup, and that was her projected outcome. And so this is, for me, something I always look at, because I'm always comparing what the patient's teeth clinically look like to the predicted outcome, because I want to come 100% as close as I can to that. You can see that at 15 months, we did her first refinement, and you could see that the crowding was still there, although to a much smaller degree. The anterior crowding on the upper and the lower still remained, and even though this refinement wasn't a complete redo, it didn't really look like we were close to the finish line. We certainly weren't close to the projected outcome. So these are the kinds of refinements that, you know, we don't really want to be doing. We want to be a lot closer to the finish line when we are doing those refinements. So what happened here? We were a pretty experienced provider. The treatment plan was pretty realistic. The patient was pretty compliant, but we didn't get those movements out of every tray. And that's why we were so behind in that final result. I know you probably feel the same way I do when I hear the word refinement. Sometimes it makes me cringe, because the last thing I want to do is, you know, start over every time I do a refinement. In Abby's case, you know, it wasn't a complete redo, but it did take us quite a bit of time to finish her treatment at 37 months. She didn't seem like a really complex initial, but we just couldn't get those movements expressed out of each aligner. And in some cases, she had to wear those aligners for 3 weeks, which after a while, you know, the patients get really not so excited anymore. They become demotivated, and that also reduces their compliance. So we certainly don't want to be having patients wear aligners that long going forward. If you compare it with Leo, we treated him with vibration technology, and you could see that he had a lot more crowding, especially on the upper. We gave him these aligners, and within 4 months, it looked like we were making some really great changes. And 6.5 months later, you could see that we had a really pretty decent result. We weren't exactly at the finish line. We were very, very close, and all we needed to do was really get his upper right canine in line more. But when you compare that 6.5 month result with the projected outcome, I'd say we were really, really close. The patient wasn't any more compliant than our last patient. We just got really good results because we got all those movements expressed. So the acceleration device really did help us in this case. Now, when we talk about doing a refinement, it's really just getting some aligners to, you know, maybe just fine tune that finish line, get the midlines perfected, maybe do a little bit more expansion. But all in all, it only took us about 12 months to treat Leo. And so I thought to myself, wow, this is really incredible. It took me 3 months longer, 3 times longer rather, with Abby. And I had to give that vibration device some credit for giving me that really predictable outcome. So now what I'd like to do is kind of share a few more complex cases that I've treated. And we treated them all with vibration devices. The first one we'll talk about is an open bite. This patient has vertical maxillary excess. She's an anterior open bite, narrow arches. She is retrognathic mandible. She's a dental student, so she's very, very well aware of everything going on. She also had a double jaw surgery, and she had a lot of relapse and was really, really disappointed. So she'd gotten other consults before who told her she needed orthognathic surgery again, and that was really the last time she went back. So for us, we told her that we would, expand her arches, close her open bite, get the midlines on, and try to improve her class 2 relationship, even though it is more of a skeletal class 2. So when we did her workup, this is my typical setup. I use the horizontal rectangular attachments on all the upper teeth. I intrude the posterior teeth to a 1 millimeter open bite. I extrude the anterior teeth to about a 50% deep bite. So we're building in a lot of overcorrection so that we can really overpower the biology and really get that bite to close in the anterior. You can see the superimpositions where we've really intruded those posterior teeth and extruded the anterior teeth to sort of rotate that maxillary arch down. We're using elastics, class 2 elastics during her treatment. And her initial setup was about 32 aligners. She switched aligners once a week, and she used her acceleration device once a day. So when we look at her results in 13 weeks, she really does resemble that ClinCheck. And at 32 weeks, her bite had completely closed down, which is absolutely remarkable and life-changing for somebody like this who's been really unhappy with her open bite, which, as we know, open bites, they affect your speech. Of course, they are an aesthetic dilemma and really have a negative impact on your ability to even be in public and eat properly. So at 32 weeks, we're looking really, really close to her ClinCheck result. We went ahead and did refinement to improve her midline, maybe do a little bit of expansion. But what I told this patient at the consult was, hey, your treatment's probably going to take about 1.5 years, but you're going to be 90% done at 8 months. And it's really, really nice to be able to deliver something like that for the patient. I do recognize, that she is VME and she's got a really gummy smile, and she knows that. And it was something that we were not addressing for her. And she was very, very happy to get this kind of result, knowing her limitations, of course. Her refinement was only about 16 aligners. We used the class 2 elastics and kept her attachments on. At this point, I could have taken her attachments off because we weren't really doing any more bite closure, but I did choose to keep them on for her. And at the 16-week mark, she looked really good. We needed a little bit more refinement. And when we think about refinement, I think it's really, really important to kind of have a very good philosophy with it, because some people will tell you take all the attachments off before you do refinement, and other people tell you keep them on. And so how do you kind of decide? I think a good way to approach it is those attachments were on the teeth for a reason, for certain goals to be accomplished. So when you get to the refinement stage, has that goal been accomplished? Can you get a little bit more out of those attachments? Can you get closer to the goal? If you can, then I would leave the attachments on for the refinement. If your goals of treatment have really been accomplished and all you're doing is doing some minor expansion or some midline correction with some elastics, then I would recommend, or at least I, remove the attachments and scan for refinement. If you are not sure, then you can just leave them on. But I typically don't want to take them off and put them all back on. So I try to avoid that at all costs. That's very, very expensive to do. It takes a lot of chair time. It's very, very inefficient. but it also does sometimes make the patient lose confidence because they'll think and they might say, hey, you just took these off and now you're putting them back on. What's the deal? So we want to be really careful with that. So in any case, that was her final refinement, which was her second refinement. Again, just 8 aligners, a little bit more class 2 elastics on the left side for her midline. All in all, her treatment was only 12 months. I kept her on elastics for an additional 2 months, which I do a lot when we're making skeletal changes. I will tell a patient at consult, hey, I think you are going to be done at this time, but we're going to need you to wear elastics for another 3 months. And it's really important that we do that because the neuromuscular system has to also adapt to these new positions that the teeth are taking. And I always tell them, you know, the teeth might look like they're in the right place, but we need time for the muscles and the soft tissue, the entire system to now adapt to that new spot so that we don't get relapse. And setting that expectation from the beginning definitely gets them to be on board with it. Because believe me, when their teeth look good, they want to bail on you. And it's really important so that we don't get that relapse. So that's her x-ray. You know, it's really important to show because some people will say that, hey, vibration technology can cause root resorption. How can you move the teeth that quickly? But as they say, the proof's in the pudding. You can see her root integrity is amazing. There's been no change whatsoever. And again, it's because we are not doing anything that's past the biology. We're working with the biology and we're making very gentle movements. So it's more of an efficient system rather than an overpowering system. Again, you know, you could see that the change that we've made to her bite, her open bite, by improving the VME just a little bit and intruding those upper posterior teeth. I love looking at the final clinic picture and comparing it to my very, very first clinic ClinCheck outcome, because I want to make sure that I am 90 to 100% exactly what that ClinCheck shows me. That tells me that all the program movements got fully expressed. And that is the only way that we can get successful results with Invisalign. Another view there where you could see how the bite closed down beautifully. I would say that she probably has a little bit more overjet clinically than her ClinCheck, and she's probably slightly class 2. And we would have, of course, loved to do that. I think it would have required some skeletal changes. I think we just kind of maxed out the dental changes that we could make. But you could just see how much happier she was. Of course, we didn't take care of all the issues, but all in all, really happy with her changes. So that was an open bite. Now we'll talk a little bit about deep bite and anterior intrusion. This patient, she is a class 2 skeletal and dental. She's got narrow arches. I would call this a double deep bite because she's got 100% deep overbite with palatal impingement, but also her upper incisors are impinging on her lower gum line. She has a really deep curve of spee, and she doesn't really have a lot of room for her upper canines or her laterals. We did put her on a vibration device with Excelident, and you can see her initial. You could have a lot of different treatment plans for a patient like this. And so we did decide we were just doing Invisalign without any other appliances. And she was, of course, thrilled with that. Her initial workup, we planned for 32 active aligners, and we asked for a 1 millimeter open bite of the anterior teeth. So again, we're overcorrecting that intrusion of the upper anterior teeth so that we can really correct that deep bite. I use the same type of attachments for my deep bite as I do for my open bite. I really love the horizontal rectangular attachments. I think everybody has their own preferences that they gain over time, but these are just my preferences. And again, we are opening up that deep bite for her and using class 2 elastics at the same time. We're intruding and really proclining her upper anterior teeth. We want to use the virtual bite ramps that you can see behind the upper centrals to disarticulate the dentition, and that's going to make her class 2 correction a lot more efficient. A lot of people don't think that you can really intrude anterior teeth with clear aligners. And I can tell you, it is patient dependent. It is really biology type dependent. I've seen this exact thing work in adults as well. And I've seen it be very resistant to correction in some young people and some adults. But more often than not, this type of setup will successfully be able to resolve your deep bite. So we actually called for and planned for in treating these lower incisors 3 millimeters to flatten her curve of spee, and on the upper anteriors about 2.5, almost 3 millimeters. Because she's young, of course, this works a lot better. She's switching her aligners every week, and she's using her vibration device once a day. You can see the setup, and within 3 months, the lower pictures and the middle ClinCheck do resemble each other quite a bit. So it tells me that we're getting a lot of the program movements fully expressed with the technique she's using. Again, another view. You can see the grayed out tooth, upper left second premolar. I will create a hollow pontic to allow a tooth to erupt into it. Instead of using an attachment and extruding a tooth, I find that if a tooth is erupting in a straight path towards the occlusal plane, then I will just create an outline that can be mirrored from the opposite premolar, and the tooth beautifully erupts into the right spot. It's a really easy way to do that. At 7 months, we did a refinement, and in her case, we told her, hey, at 7, 8 months, you're going to be 90% done with your treatment. So she looks really incredible at 7 months. And around that end of her refinement, we did 4 additional aligners. And the only reason we did that is because we did not really have her second molars in the first scan. So we ended up getting 4 more aligners once the second molars fully erupted. We did continue using the class 2 elastics, but we had no attachments. And you can see how easy this is of a refinement. We're not redoing the whole case. These are the kind of refinements I think we all love. So we finished her at 8 months, and she got a really, really gorgeous result. You can see the initial ClinCheck didn't even have the original tooth, and her final result really resembles that. We did have some overcorrection in the ClinCheck, so that's why the overbite was very, very shallow in the ClinCheck. The takeaway really from this case is that you can predictably intrude the anterior teeth with aligners. I absolutely think vibration technology helps because it's working with the biology to restructure, reorganize, get the bone cell turnover, the teeth are moving, and everything's working. We're getting all those program movements fully expressed. And you can see when we finished her, she had all her second molars in, and so she was at a really great place. And that's her Ceph, nothing remarkable there. So all in all, it took about 8 months to finish her treatment up, which was really nice. Her mom, by the way, had an open bite. So open bite mom, deep bite daughter. Next case is my friend George, who came in with severe crowding as an adult. He had been told to get braces, and he needed 4 teeth extracted. And so he said, no way, I'm not doing that. And he just walked around with that significant amount of crowding. So for George, we went ahead and treated him with Invisalign. and we gave him a vibration device to use once a day, so he was able to change his aligners once a week. So again, when you look at his initial presentation, you can see those upper and lower canines are significantly flared. And that is a huge concern. And that's why some people would say, hey, we really need to extract because we don't want those teeth to flare out any further because of the potential for the soft tissue loss, the gingival recession that he's kind of already starting to get. So when we think about this, how can we do this? How can we align these teeth without having more of a soft tissue issue? So we'll take a look at how the setup was done. His initial was 32 aligners, and you can kind of see a pattern. Most patients that I treat are always 32 aligners. It seems to be 8 months. It seems like it's a really good number of months, 32 aligners, to get a lot of goals of treatment accomplished for most of our patients. Our goals here are to really prevent flare of those canines. So we're using some IPR, and we're going to try and correct that anterior edge-to-edge occlusion by extruding the upper anteriors. We're going to be doing a lot of IPR though, and we're using some elastics. We want to make sure we have great root control. At 3 months, you can see that he's getting a really amazing tracking. The teeth are exactly the way the ClinCheck shows, and he's doing a really, really good job. At 8 months, we do a refinement. I think we're pretty good when we told him that he'd be about 90% done with his treatment. And we got him another 16 aligners, which is about 4 months. And he is using class 3 elastics to continue retracting those lower teeth. Refinement number 2 came at 11 months. We took off all his attachments. And I really wanted to close the bite on the left side and get those canine occlusion down a lot better, get some better interdigitation. So we went ahead and did a little bit more IPR, retracted the lower teeth, and used some elastics on that left side especially. With the vibration device and 7-day aligner change, he got amazing result. It only took us about 12 months. I did have him wear those class 3 elastics for an additional couple of months just to kind of keep things where they needed to be. His x-ray, you know, his teeth look amazing. And his ClinCheck really looks very similar to that very final result that we got at that 12-month mark. One of the most important things is to also look at the superimpositions, because one of our top criteria for treating him was, hey, those canines, I don't want to flare them. I don't want any more gingival recession. In fact, I want to just bring them in. When you look at the superimposition, blue is initial and white is where you end up. And so you can see with every refinement, we actually brought in the canines every single time. So by expanding the posterior, doing IPR, and bringing those anterior teeth in, we were able to really protect the gum line on this patient. So that's how he ended up. And of course, he was thrilled that he didn't need the braces and the extractions. And he's such a raving fan. He's always posting things on Facebook, and he was in a recent magazine ad for us. So it's really fun to transform, especially adults like this. It's really exciting to see. Our next patient, an extraction patient. She's a class 3, a skeletal class 3. She has a dental class 3. Her maxilla is a little bit retrognathic. Her mandible is maybe slightly prognathic, but the real issue is more with her maxilla. She has severe crowding with the blocked out upper canines. And our treatment for her was clear aligners with 7-day wear and using her vibration device once a day. That's her skeletal. You can definitely see her skeletal discrepancy in the Ceph. And we did discuss some other options such as face mask, orthodontic surgery. Her mom was a previous patient who also had a class 3 discrepancy, and we did treat her with Invisalign, so that was mom's choice for her daughter. We ended up extracting her lower first premolars and used some class 3 elastics to retract the lower anterior teeth. When we use elastics on canines and we're distalizing or using a lot of elastics on canines, I always use attachments on those canines, because I have seen when I didn't, or if the patient lost an attachment, you can get some really big rolling of the canines and really severe rotation. So I learned that lesson, and I'm really careful now. I always put that attachment on the canines. You can see that with her setup, we are using the horizontal attachments on the lower incisors, and that's going to help us intrude the lowers. And I always use vertical attachments that are rectangular adjacent to the extraction space for the best root control. I also want to overcorrect the roots. So if I'm distalizing a tooth, I want extra distal root movement. If I'm mesializing a tooth, I want extra mesial root movement so that you can get actually parallel roots at the end. A lot of overcorrections needed. So you can see her progress. At 4 months, 9 months, her spaces are getting a lot smaller. Her anterior crossbite is gone. In just 9 months post-extraction, she's really almost done with her treatment. We've got some smaller spaces to close up. And that's her 12-month post-extraction, incredibly tiny spaces left. And at the end, it was probably another 3 months with some elastics. A really amazing result for a young lady, totally life-changing. And that's sort of the change that you can get. When you look at my final x-ray, I'm not loving the way that the lower left second premolar looks. And that is a direct result of us losing an attachment on that tooth. And the vertical attachment that we had was lost. And so we did not get that mesial root movement, and we didn't catch it for many, many, many months. And so we just kind of ended her treatment like that, but I would have loved to kick that root a lot more mesially. You can see her skeletal changes, much nicer soft tissue profile, her upper lip, her lower lip, certainly a much more healthy bite. We didn't do orthodontic surgery, but she got some really, really nice aesthetic and functional changes. And we got really close to that predicted final outcome, which tells us that our predicted movements did get expressed, and I do attribute that vibration technology to that. Life-changing, and she was really, really happy with her treatment. I didn't really think that I could treat a patient like that with Invisalign, to be honest, for a long time. So seeing this type of result has given me the confidence to be able to do this on a lot more patients. And certainly I feel that today when people come in and they don't really want braces, being able to offer them a treatment like this with Invisalign is really, really nice for them. They really love it and they appreciate it. Our next patient is one of those really, really complex mutilated dentition, because in the beginning, I really had no idea where to start or what her occlusion even looked like. She was a class 3 dental. I couldn't get her into a centric relation position because of all her anterior crossbites. She had this locked in bite that I couldn't change, so I didn't even know where to begin. And I sort of told her, I said, you know, I don't really know what I'm going to do, but it's going to be amazing when we get to the end. And thankfully, she took the leap of faith. You could see that she was destroying her anterior teeth. She had a lot of chipping. She had the endo on her lower right lateral. Her dentist could not really restore her anymore because of her occlusion. Everything he did just kept busting off, just like her teeth busted off. So we knew we had to do something. She's been told her whole life she needs jaw surgery, and that's something that she absolutely did not want. So we ended up treating her with Invisalign, and she used her vibration device once a day. She changed her aligners once a week. Once a week is all we did. So her treatment required for us to distalize her lower molars. Again, a movement a lot of people say can't be done with Invisalign. You need TADs to do it. And I'll show you where you absolutely can do it and you don't need the TADs to get the movements that you're looking for. For us to get the lower molars to distalize, we need to first intrude the upper first and second molars. Otherwise, those lower teeth are just running right up against those over-erupted molars. So that was sort of the first order of business. You can see she does have some skeletal, but she is also functionally shifting. So again, it was just one of those things where we had to sort of disassemble her occlusion to really see where she was. Like I said in the beginning, I wasn't really sure where we were going. So at the 8-month mark, I was really happy to see that her anterior crossbites were at least gone. And now I can assess where I needed to go with her treatment. You can see that there's some disharmonies. Some of her lower teeth intruded. Some stayed at the occlusal plane. So I knew that I had a lot of work to do here. When you look at her 12-month progress, that was sort of that aha moment of just a really good feeling for her and for me that we were able to get her out of that really destructive bite where her joints were hurting, and from a psychosocial perspective, she was not really happy with her smile and avoided, of course, socially smiling and things like that. At the 14-month mark, we did her first refinement. Now, when I first saw her for her initial exam, I told her, we're going to align all the teeth to the best of our ability, but it looks like you're likely going to need to get crowns probably on all your upper teeth because of the occlusion. I just couldn't imagine how her natural teeth were going to have proper occlusion. So when we got to this 12-month mark, I felt like I could tell her, okay, we're done. Go ahead now and get your posterior crowns, close the bite, and do some anterior aesthetic work if you want. So I didn't do that. I actually told her, hey, if you're willing, let's try some refinement. Let me see if I can improve your bite anymore. And sure enough, wouldn't you know, she was just absolutely the most compliant person. And she wore her rubber bands and she was able to close her bite down beautifully. This is a patient who went through a significant skeletal change. And with her, I had her wear her elastics for 6 months after she was done with her treatment. And she hated my guts because her teeth looked great. She looked great. She loved how everything felt. And she kept saying, why do I have to wear my elastics? Why do I have to wear my elastics? But of course, we know she's going to get a tremendous amount of relapse if she does not wear her elastics. So we did have her wear those elastics. You can see on the x-ray how much we distalized those lower molars without TADs. So I love seeing that and knowing that we can do that successfully and predictably for a patient. You can see the skeletal changes that we made, the soft tissue changes that we made, and how close she came to that outcome, that ClinCheck cartoon that is our real finish line that we promise for every patient. You can also see that she doesn't have perfect posterior interdigitation, and it's not possible for her to because she had worn her cusp tips down from the very beginning of how her occlusion was. So we know we're not going to get perfect intercuspal interdigitation. At this point, all she needed, and I can't believe it still to this day, all she needed was 4 veneers. And she had some whitening done, and that's all she ended up getting. Of course, some of her amalgam fillings she kind of swapped out a little bit, but if I look at that, it's just remarkable to think that all she needed was 4 veneers. and she ended up getting such a phenomenal result. And the most beautiful part of treating a patient like this is to see how their face changes, their smile changes, their confidence just kind of exudes. She didn't lose any weight, even though when you look at her photos, it looks like she lost weight, but her entire structure, her facial structure just changed so much just by us changing her occlusion. And the soft tissue and the neuromuscular system all adapted to this new dental position. And look at the change she got in her face. It's remarkable every time I look at it. And this is her result, Miss Teresa. Another raving fan. She's, in our ads, and she's always referring people. And that's not really why we do this, but it is such a great feeling to be able to treat someone like this and give them that result and tell them, I can treat you. You don't need braces. You don't need surgery. You don't need extraction. Sometimes they do, but delivering that result predictably, getting those program movements expressed, telling them, hey, you'll be 90% done at 9 months, and actually being 90% done at 9 months. It's a really, really great feeling. And I think it's why we all love what we do. So in conclusion, I'm hoping that I was able to share with you a little bit about how vibration technology has played such a significant role in my practice and the orthodontics that we do, allowing us to really treat super complex and the simpler by just giving that predictability and being able to get everything out of every aligner really, really efficiently, which helps you reduce treatment times. It keeps people compliant, motivated, and that affects your bottom line, which is always the cherry on top, right? Anyway, with that, this does conclude my presentation. I'm so grateful that everybody hopefully stayed with me and joined in, and I think we have some time for some questions and answers, and I'm really, really grateful that you spent this time with me. And I think we can go to our questions. If anybody has questions, please send them by, because I only think I have a couple of questions. Let me see. I'm just learning how to use this question area. Okay. Speaking of surgical cases, do you modify your vibration protocol either pre or post surgery in anticipation of bone resorption when the bones are devascularized by surgery? So for surgical patients, I don't have them using the vibration device right after surgery. And I think it's a combination of just kind of letting them heal, not being able to even open wide enough. They've got so many other things they're kind of trying to deal with. So from that perspective, I don't have them wear it, but there are some questions also about patients with implants and patients with periodontal disease or bone loss and soft tissue loss. And I have not seen any issues with patients with implants. In fact, it's supposed to help the integration process. So I haven't seen any issues with periodontal patients either. I do modify the trim on the aligners when I have some hard and soft tissue loss so that we don't have extra retention. Other than that, I don't really modify my protocols too much. I'm not sure if I have any other questions. I'm not really doing a good job with this question part. Any other?
Hi, doctor.
Yes.
Jacqueline here. I can read aloud. I could read aloud. Okay. So we've got a few more. Where do you recommend us learning fully about proper use of attachments?
Oh, wow. I see all the questions now. It's amazing what happens when you expand your window. Sorry about that, guys. So say that again. Where was that question?
I believe it's at the top. Where do you recommend us learning fully about proper use of attachments?
So the Invisalign website has a lot of really, really great lectures and webinars that you can learn about attachments. And I think also finding a speaker that you really like and seeing what they use and seeing the results they get can help you identify yourself with that person and using their attachments for certain cases. For me, it's been more of a trial and error, trial and success, and I don't use a lot of optimized attachments for that reason. I just have a lot more success with the vertical or horizontal rectangular attachments, and I pretty much use them almost exclusively. But I know that optimized attachments are awesome too. Everybody just has their own protocol. Next question. I want to work in a systematic review about this technique. What do you recommend me to include as inclusion criteria? So, Daniela, if I don't answer this properly, please ask another question. I think what you're asking is, how do you incorporate using vibration with your patients? And we literally give it to every single patient. It becomes part of our treatment. We don't give them an option. We make it part of their plan from day one. We show it, we talk about it, and they get it, whether it's braces or Invisalign. And every patient uses it. I mean, I would say maybe less than 5% of our patients don't use it. So, and we've been doing that for, oh gosh, the good part of maybe 8 years now. It's been quite a while, maybe 7 years, where we're doing that. So everybody gets a V Pro when they start treatment here. Even my young patients, the phase 1 Invisalign patients, they get it too. I have another question. What are the most common aligner auxiliaries used by you? For example, lingual buttons. How to prescribe to technicians to leave space in the aligner for vertical eruption through auxiliaries. So I also have learned by failures. And so I do use buttons for elastics instead of the slits in the aligner. I don't really use the slits at all. I may use them as a backup in case my buttons come off. And the reason I use buttons is because when the button is on the teeth, I like to pit the teeth against each other or the arch against each other rather than taking a chance of aligner displacement or pitting aligners against each other. So I feel that I get more control to get the changes that I want because I'm actually pitting the teeth against one another. I do use buttons. For example, for class 2 patients, I only put buttons on the lingual of the upper. I never use, you might have seen some cases that I had them on the buccal. Sometimes I put in buccal and lingual, but my preference is lingual buttons on the inside of the upper posterior teeth for class 2 elastics. Most class 2 patients need maxillary expansion. So if your buttons are on the buccal, you're actually getting constriction where you need expansion. Class 3 patients, the same thing. I use my elastic buttons on the lingual of the 6s and the buccal of the 4s so that I'm expanding the posterior as I'm distalizing the mandibular arch. I do use buttons as well for rotating premolar teeth. I typically don't use any derotation attachments. I find that I have much better luck when I put buttons on the buccal and the lingual, just like when you're derotating teeth with brackets. And so that's typically what I do, and it works beautifully. how different are your results with VPRO when using braces versus Invisalign? So the reason that we use VPRO with braces is very different from why we use it with Invisalign. With Invisalign, we have to get those program movements out of every aligner, and we want 100% of every movement. And we don't have a real good way of quantifying that. In other words, we can't measure it. I mean, now we can with, you know, artificial intelligence with dental monitoring, but we want to be able to predictably get all those movements. So that's why I love the VPRO with my Invisalign patients. And it allows me to change aligners once a week instead of 2 or 3 weeks. And it also makes up for a little bit of non-compliance. If they kind of cheat a little bit, we get a little bit more out of it. The reason we use VPRO with braces is mostly for comfort. The movement is also much more efficient. We use self-ligating brackets. Innovation is what I've used for a very, very long time. And you do get a lot of alignment and expansion in that friction-free system, a lot quicker, more efficiently with a device like that. It just, you'd be amazed at how quickly the teeth align. But we really use it for comfort, because that patient, the day they get their brackets on, they use that VPRO for 5 minutes and it's like a miracle worker. And some people say that it actually, they feel like it might prevent them from getting more discomfort. And then they don't have to take, you know, over-the-counter meds for comfort as much as they would. So those are the difference in why we use VPRO with brackets versus Invisalign. Any more questions? Any more questions? I hope I didn't miss anything.
Hi, Doctor. There are a few more.
Okay.
I can read aloud if it's easier.
Sure.
Let's see. This kind of relates to a previous question, but how do patients with braces react to VPRO?
Our patients love VPRO. Some of them don't want to stop using it when they're done with their treatment. They use it with their retainers. I will tell you also that sometimes I use Vivera retainers by Invisalign. I love them, and we use them exclusively for all our Invisalign and all our braces patients. Some people maybe get a little lazy. They don't use their retainers the way they should, and maybe they skip a week or whatnot. They start to get a little bit of lower anterior crowding. If they put their retainer in and they use that VPRO once a day for 5 minutes, within a week to 2 weeks, their teeth straighten up right back into that retainer. Now, it can't be for 3 months, but if we catch it soon enough, we can definitely get the VPRO to kind of get those teeth back in line and do it much more comfortably. So patients love it. They absolutely love it. And again, we don't give a choice. So when they start in the consult, we tell them, this is what you're going to get. You're going to get this, you're going to get this, you're going to get this. And it's an expectation. And people know that we give it, so they come in expecting it as well. Word of mouth, siblings, family members, and so on. I see a question, how do you charge patients for VPRO or include it in their treatment fee? So we do both. They do pay for it, but it's included in their treatment fee, so it's part of their recurring payments. We do recurring payments, it's interest-free, and it just becomes really a minimal extra cost for the patient. They don't even say anything about it. And again, it's because it's not an option. It's not like it's an upgrade. So it just kind of rolls into their monthly payments and becomes a non-issue really. In the beginning, I couldn't imagine how I would do that. I thought, how am I going to do this? Do they need to pay in full upfront for it? Do I need to have them pay, 50% at delivery, 50%, a month later? And over time, I realized that I just roll it into the treatment fee, and it just becomes, they get the VPRO, they get the Vivera, they get Invisalign, or they get braces, and that's just kind of the package deal that we offer. Because patients do somewhat finish sometimes a little earlier, I used to also worry that, hey, they're going to stop paying because they've finished their treatment early. And that is just something that doesn't happen. We explain it as we are extending payments for you as a courtesy, so that we know that your treatment time is going to be shorter than your payment plans, but we're going to extend that to you as a courtesy. However, we do see patients for their retention phase, which is part of orthodontic treatment, and that retention is a year. So that those payments are still coming in during those retention visits as well. So we haven't really had trouble with that. That is a question that's asked a lot. Have you had a problem with V-Pro, and if so, how have you solved it? So I will tell you, Propel has amazing customer service, absolutely fantastic. And any problem that we have, we work with our awesome rep, or we call customer service, and they just kind of help us out. So it's been a breeze. It's been amazing. We haven't had any issues at all. Sometimes, you know, maybe one doesn't hold a charge or whatnot, but I would say it's very, very minimal that we have any issues in there. They've been really great with the support. Any other questions? I'm happy to talk forever. So I'm happy to take any more questions if anybody has them.
Doctor, I'll just read these last two that we have here, and then I think we'll wrap. Do you use micro-osteoperforations at all in your practice, and do you use it in conjunction with V-Pro?
I do not. I know there is, you know, a large group of practitioners that use it, and I know that they see a lot of benefit in it. I personally, in my practice, have not seen the need and haven't needed to use it, so I do not know.
Okay, thank you. And last one, I noticed that you don't use any or many optimized attachments. Is there a reason why? When I take Invisalign courses, I was taught that when you don't remove the attachments prior to scanning for refinement, any of the optimized attachments turn into conventional attachments.
So I generally don't use optimized attachments, and I guess I've kind of I've had this protocol, this setup that I use for, if it's an open bite, I do this. If it's a deep bite, I do this. If it's extractions, I do this. And so I kind of have my distalization protocols, etc. And I've developed those, and they've been working great for me. And they do have the rectangular attachments, both horizontal and vertical. So that's really all I use, but it is really personal preference. As long as it works in your hands, you know, then that's all you need, right? As far as removing attachments, I don't know that they would turn optimized attachments into conventional. I think that is something that you would have to pretty much write in your comment box and say, if you scan with attachments, say leave the attachments as they are, or please remove and place, etc. So I think that you have a lot of control over that. Again, the way I choose to remove attachments or not is really based on the goals of treatment. If I put those attachments there, they're for a reason. And if my goal of treatment wasn't accomplished, I'm going to keep my attachment on. If it was accomplished, then I take those attachments off for refinement, knowing I'm not going to put them back on. So that's usually what I do. I love these questions. You guys are awesome. So can you share your protocol for different types of Invisalign cases? Yes. So you saw the open bite, which is horizontal rectangular attachments on all the upper teeth to intrude the posterior and extrude the anterior. It's really opposite for deep bite. I'm intruding the upper anterior. I don't really extrude posteriors in deep bites because they come back. You know, the deep bite's gonna get deep again. So I feel that if I extrude premolars, the deep bite is going to return those premolars going down again vertically. So I don't really extrude premolars. For extraction patients, I use vertical attachments, vertical rectangular attachments, as long as I can get on the tooth. So the longer the better. If I'm opening space for an implant, for example, if somebody's missing a lower lateral, I use the rectangular, vertical rectangular attachments as well, adjacent to the extraction space. If I'm distalizing upper molars for class 2, I use vertical rectangular attachments for root control and distalization. And I use buttons on the inside of the upper, buttons on the outside of the lower for class 2, elastics with expansion. I don't know if I'm missing a few protocols, but that's in general what I use. If you have a specific one, I'm happy to answer that. Anything else? You seem to get the questions quicker than I do for some reason.
Okay, I do see one more. You use VPRO for containment at the end. Oh, I think this person means for retention. Do you prescribe for retention?
So we have started doing that. It really is patient dependent. Some people will use it and some people are just really just kind of sick of the whole process. They don't really want to do anything more but pop those retainers in. But I do believe in it. I think it's great. It's a great protocol. If you can get the patients to use it, absolutely love the idea. Definitely if you get a little bit of relapse, I love to recommend it and it works. So we always tell them, hey, keep that VPRO in a really safe place because you might need to use it.